Ladies and gentlemen, I would like to thank you all for joining this lecture. I think Crohn's disease is a very important disease. I have been reiterating this for a long time. I think time has come for us to realize that it is all over the country, and every child is at vulnerable and at risk of developing this disease. So it is very important for all postgraduates and all the other doctors be aware that once a disease which is considered as a disease of a Western world is now at our doorstep, and it is important to early diagnosis and treatment provide to prevent the bowel damage. So I'll start with a small video which I would like to show you. So what I believe is in Crohn's disease, their gut is on fire from mouth to anus, right? So it's our duty as doctors to extinguish this fire and make them comfortable. So how are we going to do that is the question. So that is, this lecture will provide some answer to those questions. So the outline of my lecture would be, why should we concern about Crohn's? What are the pathological models of Crohn's? How to evaluate child with possible Crohn's disease, and current management of children with Crohn's disease, and what are the future perspectives that hold them. So, why should we concern about Crohn's disease? The incidence of Crohn's disease is on the rise at basically in alarmingly high rates, especially with the economic transition and improved socioeconomic status of the world, right? Now, once when I can remember when I came back as a consultant in 2005, I saw my first case in 2006, and after that it's extremely rare, right, for somebody to come with Crohn's disease. Then I saw my first ulcerative colitis child in this country 14 years ago. Now she's 14 years and she's still surviving. So that was a disease, not very common. We would see one child in every 3, 4, be 6 months sometimes, and it was like that. Nowadays, it's basically we at least diagnose somebody once a week. Like if I combine my both private practice as well as the government practice, you would find somebody almost one a week. Like, so the disease is common now, right? Now we put a significant burden on our already overstretched healthcare system, Sri Lanka, because most of them ended up having biologics, and which are not very cheap drugs as well. It demands highest degree of expertise in diagnosis and management, right? And it leads to significant bowel damage if we don't intervene at the right time and treat, without waiting. It leads to bowel damage, and ended up, some of them with ulcerative colitis ended up having cancer tendencies. So it is very important for early diagnosis and early treatment. We will come to that in a minute. So that is why we are talking about this disease today at the opening of this webinar series. So what is the epidemiology, and what are the current and future trends? What future hold for us with regards to Crohn's disease is important to know, right? So you can say Crohn's disease is a disease of the Western society, and hide your head like ostrich, hiding their head in the sand and wait, right? This is not the right way to approach. It is common, right? It is common, so that we recently, about 3-4 years ago, we formed this Asian Pediatric IBD network, right? So people from these two ladies from Singapore, Thailand, Malaysia, Thailand, and these three are from Hong Kong as well as Philippines, and that's myself from Sri Lanka. We formed this PIBD group to study epidemiology of IBD and their presentations and all that in a very basic way in certain Asian countries. So, what did we found? We found Crohn's disease is on the rise in Asian children. I'm not going to show all the data, but some of the important thing, right? So you can see the red part of the bar is on the rise, right? It's there, right? Ulcerative colitis is also there, but basically this is on the rise, right? These are the cases that was detected during that time when we early introduced this network. So at that time it was about 7 Crohn's disease we had, but this is increasing now. Actually, its total number is about 30 to 40, right, in our database. You can see everywhere we have Crohn's and ulcerative colitis, right? So it's all over the Asia basically. Right. Now, you need to understand what is going to happen to us in a global perspective. Now, imagine the first case of ulcerative colitis was reported in the Western world by Sir Walter Wilkes, right, in 1859, right, somewhere here, right, and it took about a century for them to, have century and a half, like, right, for them to have very high incidence. Now, first case of ulcerative colitis was detected in outside the Western world in China in 1956. Right now, we are on the rise. Right, on the rise. Right. So nobody in this world is escaping. No country is going to escape from seeing Crohn's disease. So we are on the rise. I will show you it in the next slide. What future hold for us. Right. Crohn's disease has 4 epidemiological phases: emerging, accelerated incidence, compound prevalence, and prevalence of equilibrium. So let me get everything together. I will show you, right? Right. So look at the Western world first. Now it took about almost, 200 years for them to have. They have their emerging phase, right? Very slowly, right? Very slowly, right? The accelerated phase on the Western countries is between these 50 years, 1950 to 2000, right? You had the accelerated phase and compound prevalence. So compound prevalence is incidence and prevalence both together, about a high number of cases from 2000 to 2030, like, and we expect them to have very high disease burden in 2050 onwards. Now, newly industrialized countries, China, Korea, all that. Now, they took their emerging phase is about 50 years, right? Now, their accelerated phase is about 20 years, right? Compared to this, right? And they will be ended up also having the same thing. Now, we are in the developing countries are in the emerging phase. Our emerging phase is much more less than most of these places. Now, our accelerated phase will also be less. So by, you can imagine what is going to happen to us, right? So we will be also having very high disease burden in years to come. I may not live to see that, but young pediatricians will definitely encounter these things, right? You will have the problem, so it's better to learn, right? So that is the state of affairs at the moment with regards to epidemiology of Crohn's disease and what future hold for us in probably 2000. By 2050 we will be having very high burdens of Crohn's disease and ulcerative colitis in children, right? The question is, ladies and gentlemen, The biggest question I'm going to ask from you in this evening is, are we ready to handle this? You can think of what is going to happen to us. So let's look at the certain pathological models. Why? I mean, everybody knows this is a multifactorial disease, right? So let's see what is happening, right? It's caused by dysregulated immune response to commensal microbiota in a genetically susceptible individuals, leading to inflammation of the intestine. Right? That is what it is. It compounds an immune response to commensal microbiota, right, in a genetically susceptible individual. So three components: dysregulated immune response, microbiome altered in a genetically susceptible individual. Right. Now, genetic susceptibility. You can see monozygotic twins have 20 to 50% higher tendency to develop this. Dizygotics have about 10%. That shows, genetic susceptibility of Crohn's disease in a very simple manner. Now, what are the environmental factors? Some of these things affect children, some are not, right? But whatever. Now, what about this one, right? Early exposed to antibiotic in younger age is a very clear risk factor which alters the microbiome and predispose children to develop these things. Appendicectomy, use of antibiotics in livestock, right? Not only us, livestock, right? Others are more or less related to adults, like smoking, OCP, and appendicectomy is all that. Now, what are the things that can reduce the incidence of risk of Crohn's disease? Is going back to our original, farming communities, right? That is the way forward if we want to prevent Crohn's disease, but we can't go back there, right? Living in a farm with animals and drinking unpasteurized milk from cows, there's our dreams like, but that has reduced the incidence in certain communities. Right. Now we have the current situation. Now, incidence of IBD in France and Asia in 1990s were associated with introduction and promotion of packaged food and fast food chains. That's very clear. Right? It is association. This association has been debated and questioned, but the epidemiological data shows very clear association there. Right? Consumption of fat, refined sugar, and fast food has increased in both developed and developing countries for last decades. Right? This process has led to for us to eat low fiber and high fat diet. This is not even in Sri Lanka, across the world, whether they are developing countries or developed countries. Diet low in fiber increase the risk of Crohn's disease, and food additives like saccharin, sucralose, and carboxymethyl cellulose, polysorbate, all these are known to associated to increase the risk of Crohn's disease, both in children and adults. Now, this cartoon is very important. Now, imagine this, the light blue color is our normal microbiome, healthy normal microbiome. So while we are breastfeeding and having, a natural food and living with animals, we have this normal human microbiome, right? Now, when you start to consume antibiotics and smoking, contraceptive pills, and all that lead to some degree of pathological alterations, right? Altered microbiome. Now, in the latter part, when you start to eat fast food, high sugar, high fat diet, the microbiome become really pathologically oriented. So, healthy microbiome become IBD-like microbiome, right? So that you are ready, the microbiome is ready now to go into the IBD level. Now you only need a small break in the mucosa, right? So you have it after acute episode of gastroenteritis or something, some tiny reason, the intestinal epithelial barrier breaks, the pathologically oriented microbiome goes in and engulfed by macrophages and presented to T cells through the MHC class 2 molecules, and then the CD4 T cells develop into various type of T cells which secretes all sort of inflammatory cytokines, right? So now you have cytokine war. Some of these cells migrate into blood vessels and go around the body and causing extra intestinal symptoms. So that is what is going to happen to us, right? Now, right? So this is it, right? Now what? So this is that was the pathological model that I was talking about. So you need pathologically oriented microbiome seeps into submucosa and start a inflammatory cascade. So that leads to Crohn's disease. So how do we clinically evaluate them? What? What can we do? When to suspect Crohn's? When to suspect? You all know this, right? Right, abdominal pain, when there is abdominal pain and chronic diarrhea, weight loss or growth faltering, blood in the stools is more common in ulcerative colitis, anemia, unexplained anemia, perianal lesions. These are the features of Crohn's disease, more in favor of Crohn's disease. Now, blood in stools can occur in Crohn's colitis, obviously, but it's more common in ulcerative colitis. Right. These are the extraintestinal symptoms that we saw when we start to analyze the PIBD data across the Asian countries that we studied. So you can see stomatitis, recurrent aphthous ulcers, right? Autoimmune hepatitis, arthritis, erythema nodosum, pyoderma, and eye manifestation and orofacial granulomatosis were not very common in our populations of Crohn's, right? We just, this paper just accepted from the World Journal of Gastroenterology, so you'll be able to see it very soon. Right. What are the initial investigations and their expected results? I generally do, if I suspect Crohn's disease, I do very few investigation, right? I would do complete blood count to see thrombocytosis. Almost everybody has thrombocytosis, right? I would do CRP, which is elevated somewhere between 20 to 50. You are not going to get 80s, 90s like that, right? And liver function test, I don't do full liver function test, but you can do, right? I see hypoalbuminemia, right? The stool examination would be really important. Stool cultures you can rule out bacterial enteritis. C. diff toxin can be checked, and if the diarrhea is more prominent, you can try Cryptosporidium and Giardia. And Fecal Calprotectin is a very important investigation, but I doubt its value right now in Sri Lanka. So it's a good marker of intestinal inflammation. Look at the next slide, right? I will show you in the next slide. So normal blood test does not rule out Crohn's disease, remember, right? And if you have a high degree of suspicion, go ahead and do a colonoscopy and upper GI endoscopy, right? Identify pathogens, right? Identification of bacteria in a stool culture does not necessarily exclude IBD. Both enteritis and Crohn's disease can coexist. As I said, first episode of flare-up Crohn's disease may be triggered by enteric infection. So, calprotectin is a very important thing that you need to understand this very well. Calprotectin is a calcium-containing antimicrobial protein that make up 60% of cytosolic protein in neutrophils, right? So neutrophil have this calprotectin. Now, when there is acute inflammation in the intestine, this neutrophils release calprotectin into intestinal lumen, and that is how you get fecal calprotectin. It's highly sensitive and specific to diagnose Crohn's actually, right? You can differentiate IBD and IBS by looking at calprotectin values. So value above 150 micrograms per gram is, very suggestive of Crohn's disease. What is happening in Sri Lanka is not acceptable. We just get a report whether it is positive or negative, right? No quantification of calprotectin at the moment. So don't depend on that and go ahead and do colonoscopies, because it's almost always, wrong, right? We need values. We have been discussing this with laboratories of the private sector. No one is willing to do that because of their commercial interest. Right, endoscopy. When you suspect IBD, please do both upper and lower GI endoscopy in the same anesthesia go. Don't do a colonoscopy and come out, because it is very important you look at the upper GI tract as well. Most of the time you might see acute gastritis, gastric erosions, esophageal erosions, and duodenitis. If you don't see anything in the macroscopically when you put the endoscope, at least take 2 biopsies from duodenum, gastric antrum, gastric body, and the esophagus. Otherwise you miss, you really need disease mapping, right? Which is very important. So you can't do disease mapping without doing both upper and lower, right? So when you do the lower GI endoscopy, you go up to the ileum somehow. So you take biopsies from terminal ileum, cecum, ascending colon, transverse colon, descending colon, sigmoid, and the rectum. So that is essential, right? Don't take 2 biopsies from randomly 2-3 places and come out. It is not going to be very helpful, because we need to know the disease extent of the disease, which I call disease mapping of the disease. Right, here you go. You can see some of the after ulcers here, right here. Yeah, cobblestoning appearance, linear deep ulcers, right, and deep ulcers with skip areas. You can see here, right, as well as here, right, small polyp as well, right, fistulae, right. We do see all this actually, even in Sri Lankan children. These some of the pictures, some of them are my pictures. This one and that one is from my friend Supron from Thailand. So we do see all this, right? So remember, when you see this, I take a couple of biopsies and right places. Now this is histology, right? Histology, very characteristic histology in Crohn's disease. First thing you see is, now these are the normal crypts. You see crypt distortion. You can see very clearly distorted by the chronic inflammation. Now focal inflammation, you can see normal area, abnormal area, right? This is classic non-crescitating granuloma. Got to see with, these pictures are from Professor Janaki Hevavisanti, who spent half of her life studying IBD histology in Sri Lankan adults as well as in children. Magnetic resonance enterography. Now you can see up to the duodenum from upper, ileum up to ileum from the lower, but in the middle you don't know what is happening, right? So it is essential you do MRE, magnetic resonance enterography, in every suspected child with Crohn's disease, because you never know. As you all know, Crohn's disease is a disease which is affect from mouth to anus, so intestinal is not spared, small intestine. So you might see narrowing and all that. These are normal images, right? There's no Crohn's disease here, so you can see images and make sure you know where this disease is in the intestine. So once you have the disease mapping, you know exactly what to do and what to expect in these children. So now that is why I call it disease mapping. So you know what is happening in the upper GI tract, you know what is happening in the middle, you know what is happening in the lower. So now you are ready to attack, right? So what is the current management of children with Crohn's? Now I have questioned before, why should we treat them urgently and efficiently? Now look at this. Right. Based on current evidence and concept, if you treat them urgently and efficiently, you can minimize the bowel damage. You have to be in this concept of minimizing bowel damage is the cornerstone in treating children with IBD. And you always try to aim to minimize the bowel damage. Right. This approach will reduce suffering, right? Improve the health related quality of life, minimize bowel damage, and reduce extraintestinal complications, reduce long-term disability, minimize the cancer risk. All this can be achieved, right, with early aggressive treatment. So now this is important, right? This is the traditional model, right? You try exclusive enteral nutrition first, and then you try steroids, right? Right. We try steroid first, and right, then go for biologics. This is the traditional approach, right? This is the traditional maintenance model. Long term ago, I put this, right? Long term ago, they use sulfasalazine even, right? I mean, I often see some clinicians use sulfasalazine as a maintenance for Crohn's disease, which is very wrong actually. Nowadays, none of the guidelines say use sulfasalazine for maintenance. You start with azathioprine, methotrexate is around, biologics are for maintenance nowadays. Biologic plus azathioprine is a good way of maintaining remission. So this is a traditional model of maintenance. So you go one by one. Now, as time goes, you can see the cumulative risk of complications. If you don't achieve remission early, right? This is the bowel damage that you will do, right? You just destroy their bowel if you don't treat them properly. This data from Korea, right, where they have huge pediatric population with Crohn's. So they think if you don't treat early, this red color one is not very good, right? This is a B3 disease, right? So the B3 is, intestinal damage is high. So look at the way that we go around, right? So traditional management, so we start as a azathioprine, then they relapse, we reinduction and try methotrexate, then they go to Vedamahatya, forgetting about the doctor. So they wait there and get some decoctions from him, and then probably come in a very, very desperate situation to your ward again. Then we do reinduction, giving steroids, then you go as a therapy. We go on and on this cycle. While we are on the business as usual model, what is going to happen to these children? They develop extraintestinal damage, their psyche is going to get damaged, their joints are going to get destroyed, right? They have poor quality of life. Their bowel get destroyed, inflamed and stricturing and perforations, damage to the core of the bowel, and they become really disabled, and they have cancer risk, and they are absolutely at a high risk of death, right? Recently, we had a child whose inflammation that we just could not control with any of these things. It was a late presentation, so bowel is destroyed. There were so many perianal fistulas. We decided to take his whole bowel out. The child was very happy to give the consent because he knew he can't live with that bowel which is damaged to its bottom. We took out the bowel yesterday. I don't have pictures, I'm afraid. I will show you in another day, right? It is nothing, like, band of fibrous thick tube, right? So now he's on ileostomy, but he will live happily with that ileostomy, I'm sure, because all these things we have taken away. Now you can be ostrich again, saying, no, that is not very common. In fact, that is very common if you don't treat them properly, or if you keep on doing the traditional things, right? Future perspective of care for children with IBD. Can you give me 1 second, please? I'm getting a call from the hospital. right? Sorry about that disturbing. So what is the future perspective? Now, look at what we were trying to do few years ago. We target clinical remission and response, control the disease activity, facilitate normal growth, and stepping up the medication and treat all patients in the same way. Now, we are doing something totally different. We aim for deep mucosal healing or deep mucosal remission, right? Which is very important. We do induce remission with steroids or infliximab, whatever the decision that are taken at the beginning, and follow up with a colonoscopy. If the fellow is not having adequate control, we step up treatment without waiting around the preventing bowel damage basically. So this is we are not trying to control the disease activity anymore. We are moving to a disease modifying treatment, right? So we all still aim to facilitate normal growth. We step up medication, or we accelerate it now. Actually, we just don't want months and months to make a decision to go to next drug. If they are not doing well by 6 weeks, we move on, right, to the next step. If they are not doing very well there, we have now new model called top-down model, right? We will show you. And each child has their individualized treatment plan. Right, this is the novel model. So we don't wait, we aggressively treat with early biologics, with immunomodulators, and follow up with very tight control. This is what we are currently doing. You don't wait till their bowel gets shrink and strictured. So what are the indications for early biologics? Extensive disease with deep ulceration. You can remember deep ulceration, I'm sure, right? Stricturing or penetrating disease, right? Severe growth failure. Poor response to steroid at 12 weeks. We just don't wait. Perianal disease, severe osteoporosis, all these are very good indicators for biologics, early biologics. What do we have here? We have infliximab, which is a chimeric anti-TNF antibody. What is chimeric anti-TNF? Chimeric anti-TNF is infliximab is formed by anti-TNF antibody prepared by half murine, half human. So you can develop antibodies against infliximab. So then we found adalimumab. Adalimumab is a humanized anti-TNF antibody, right? We have vedolizumab. It is another antibody to, I'll show you in a minute, right? Anti alpha 4 beta 7 integrin antibody, right? And we have ustekinumab, which is humanized anti IL-12 IL-23 antibody. So we have all four. At least we have these three in Sri Lanka, which we use sometimes. We use vedolizumab for one child, right, who was ended up having surgery because I think it's also too late, right? So how do they work? Now look at this, right? Infliximab, adalimumab, certolizumab, and golimumab are all anti-TNF antibodies. So they neutralize TNF, right? Now ustekinumab, as I said, IL-12, IL-23, IL-12, IL-3 antibody. So neutralize this path, right? And vedolizumab is anti-alpha 4 beta 7 integrin antibody, which blocks the T cell migration, right? So these are the antibodies, biologics that we use at the moment. There are so many biologics that have been used in adult trials, right? We are not having that luxury at the moment, but this is, at least we have 4 that has been tried on children. So that is how they work. So what are the practical ways? If you come to Ward 1, Pediatric Hospital, you will see this, right? You do screening for tuberculosis, hepatitis, and all that before starting therapy. We do that as, we call it as pre-med workup, and then we use Infliximab usually induction dose is 5 milligram per kg as an infusion, right, in day 0, week 2, and week 6. That is the induction therapy, right? Then follow up with maintenance therapy with IFX or, every 2 monthly, and depending on their response, we increase the dose, we jack up the dose up to 10 milligram per kg, and we can increase the dose frequency to monthly, right? So there's no hard and fast rule. We can alter according to the response of the patient. Adalimumab, the starting dose is 40 milligram, right? Give it on week 0, 20, week 2, right? It's given subcutaneously. It followed by every 2 weekly injections subcutaneously. Now, you don't develop antibodies here for adalimumab, but for infliximab, you can develop antibodies. And ideally speaking, you should have therapeutic drug monitoring. We don't have it at the moment. So we haphazardly sometimes with the depending on the clinical response we change. But in ideal setup, you have therapeutic drug monitoring, you know their trough value, and then you can change accordingly. Combine or monotherapy, right? You can go with combine monotherapy with infliximab, or we can combine it with methotrexate or azathioprine, right? Can use 2 to 2.5 milligram per kg per day of azathioprine, right? Or you can go with methotrexate or methotrexate. You can use it initially as combined therapy and then go back to monotherapy depending on the clinical response and your experience, right? And combination can be continued, but there is a dreadful disease called hepatosplenic lymphoma, which is more common when you use IFX plus azathioprine together, right? So you assess the risk benefit ratio of giving these things with regard to their long-term repercussions, right? This has been reported about 30 children in the world across, right? And it is incurable, it seems, right? So I hope not to see one of them again in our cohort at least. And we use combination therapy often actually, right? Adalimumab generally used as a monotherapy. I wholeheartedly believe biologics are going to be the future. So you can use a steroid still occasionally, but if you don't know about biologics, you're not going to treat Crohn's disease properly. Biologics are the future, no doubt. But you need to balance the risk and benefit. So it gives maximum mucosal healing, right? Healing and improve growth, right? Right. Minimize adverse effects like infection, malignancies, adverse drug reactions. You need to think about all that when you are using biologics, and it is expensive as well. Um, 50 milligram vial cost about 60,000. Those days when they started, it was about 130-40,000 one vial. Now their patents is over. Now biosimilars are coming into the market, so half a price. So we using biosimilars. Adverse effect on IFX is infusion reactions, dermatological manifestations, opportunistic infections. The risk of malignancies is still there. Neurological events can be seen in some of them. Autoimmune phenomena are known to occur. So really need to know that. Indication, when do we need our surgeons? Now we can do segmental resections. Actually, the commonest manifestation of childhood Crohn's disease is ileocolonic Crohn's. And if you have isolated ileocolonic Crohn's disease, the best management option is not to whack a steroid or not to give IFX. Take that segment out and make an anastomosis at the outset, very beginning. Take that out and try. Then you try to maintain with the other drugs. You're going to be very successful in that sense because you take the segment which secrete all toxins out of body, right? So segmental resection. You need to drain perianal abscess in Crohn's, and it is messy, very. To perform stoma, sometimes ileostomy, we recently had to do one. I think it was in October. One child came with very small child, 14 years, came with short stature and diarrhea. We did the colonoscopy, found nothing. The biopsies were normal. And then we had this feeling of vague mass in her right iliac. So when we asked Naveen Vijayakorn to go in and see, he saw full-blown Crohn's, right from the, it can affect the whole mural thickness. So the part was, it has affected the muscularis part than the mucosal part. So we took that part out, created ileostomy, start IFX, is doing well. So sometimes the colectomies, as I said, yesterday we did this colectomy at Ragama, taken the colon out. We can create pouches. Sometimes we create pouches with help of our surgeons. So, what are our take-home messages, ladies and gentlemen, for the evening? Crohn's disease is increasing at an alarmingly high rate in Asia, and it's only a matter of time we are facing the epidemic of Crohn's disease in Sri Lanka. I have absolutely no doubt about that in my head. Although complex, pathogenesis has become clearer. It's depending on three things: dysregulated immune response, altered microbiome, and genetics. We are studying adults' genetics. Recently, we submitted already that as an abstract to DDW with the collaboration of Emory University of Atlanta, USA. We studied about 340 adult patients, and we found some new mutations actually. So we are presenting that. We are collecting blood of children or to do the same thing in children, but we need larger sample. So we are still collecting, keep on collecting, and we will definitely be able to describe some new mutations. High degree of suspicion coupled with evaluation of the intestine will provide a complete diagnosis, which I call disease mapping. It's very important. Controlling inflammation is the priority in the management. Early use of biologic in children will clear indication is the way forward. Well, thank you very much for your patient listening.